There's no such thing as a silly question, so feel free to pop anything in the chat or just write straight to Darcy if you don't want to put it in for everybody. Yes, we run these seminars to support people to understand the health systems and manage their health conditions, and these are put on for free, and Dr. Grant is volunteering his time tonight for free, so we're very, very grateful to have him. So I will now introduce Dr. Grant Wilson. He is a physiotherapist with over 20 years experience in sleep medicine. He has Why am I muted, Darcy? Was that you muted me? Okay. 20 years experience in sleep medicine. He is a PhD in medicine from the University of Sydney. He's founded the Sleep and Lifestyle Clinic here in Phillip in Canberra, and working with clients to improve their sleep and conducting research into new treatments for better sleep. So he's going to give our slideshow presentation tonight. So hopefully his screen should be already shared and everybody should be able to see the first slide up there now. It'll go, so we've got 6 till 7:30, so we'll start rolling. So over to you, Grant.
Great. Thanks very much. Thanks for everyone for putting aside the time to cover this sort of really important topic, and I'm hoping it'll be a practical presentation and that you'll be able to get something practical, but also learn some theory about sleep tonight. So, so as it was said in the introduction, let's get this first slide. Yep, I'm an academic at the University of Canberra, and I mainly teach evidence-based practice, which is teaching the students to interpret the medical literature and be able to apply that to their practice, to be able to administer the best diagnostic techniques and treatments for their patients. And so many of the things that I say today in terms of advice will be underlying it will be large amounts of research which has been undertaken on real patients in clinics. So my other affiliation is with the Sleep and Lifestyle Clinic. We're a clinic here in Phillip. We undertake home sleep studies where patients are referred from their GP or specialist with a suspicion of a sleep disorder. They take home a kit and monitor themselves overnight, and then we advise in regards to the need for therapies and various therapies, and then we administer therapies mainly for sleep disordered breathing, but also we're doing things like I'm talking about tonight around getting a better night's sleep for people. We sell medical devices, and we sell them from ResMed, which is a brand you may have seen. It's an Australian medical device brand that makes CPAP machines for sleep apnea. So just in sort of introduction to the presentation, a few really important points about the presentation is that I'm just presenting generic information about sleep and about different recommendations that could be made to improve someone's sleep. I'm not saying that those recommendations are specific to you, and so really the sorts of things you get from the presentation you should discuss with your own health professional, whether that be a GP or a psychologist or whoever, just to see if what I'm saying is going to be good for you. I will not be discussing things around pharmacological agents. So I'm a physiotherapist by training, and so I'm not trained in pharmacological agents, and in fact it's illegal for us to talk about such things. So you should ask your doctor or pharmacist, and I think that's appropriate for a talk of this nature because the use of these agents are very specific to an individual person's circumstance. The interaction of these medications with other medications, the interactions with the person's condition. So I won't be discussing that. But if you talk to sleep professionals, what they will say is the sort of stuff that I've got in this presentation about behaviours and the way we think about our sleep really are the most important and underlying things that we should be focusing on to improve people's sleep. So I will also be taking some questions, but I can't really respond to questions about you and your situation. So please try and keep your questions of a sort of general nature and related to the subject matter of the presentation would be great if you could. So these are what we're going to cover tonight. We'll talk about normal sleep and the impact of chronic conditions on sleep. We'll survey some common sleep issues and then give you some practical things that you could think about and do to improve your own sleep. So what is sleep? Well, you might have had a circumstance where someone's pretending to be asleep. For example, maybe a child or whatever, if they've been naughty, they'll go to their bedroom and pretend to be asleep so you won't arouse on them. So sometimes it is hard to tell if someone's lying there very quietly with their eyes closed, whether they're asleep or awake. And one of the ways we can solve that problem in the sleep lab and in research is to actually measure directly the signals of sleep. And they are the signals that we pick up from the brain, the EEG, the electroencephalogram. So brain waves change when we sleep. Generally, they slow down when we sleep. There's changes in the way the eyes move. So as you start to go off to sleep, your eyes start to roll in your head. And sometimes, you may have noticed somebody's drifting off and you'll see their sort of eyes rolling. And then there's changes in muscle activity as well. So we usually lie down to sleep because we know that the muscles will relax. And I know that even some of you in this talk this evening might be sitting there and you'll start to feel your head nodding as you start to nod off. Even though I'm delivering a scintillating presentation, you might start to notice that you get a bit noddy and your head starts to nod on your shoulders. And that's just an example of the changes in the EMG. The muscle activity relaxes. And here you can see measuring these various physiological signals to measure sleep. So this is just some examples of the electroencephalogram, the brainwave activities as we change from the different sleep phases. So here's wakefulness, where there's quite a rapid brainwave, about 8 to 13 hertz. And then as we fall asleep, the brain waves become mixed frequency and a larger amplitude. And we go into deeper sleep, which has these distinct brain waves that occur, what's called a K complex, like these big V waves, and these things called sleep spindles, these rapid 12 to 14 hertz bursts of brain activity, which last about, at least half a second. And then the really deep sleep is stage 3 sleep, where we spend about 25% of our night. It's very high amplitude and low frequency. And in stage 3 sleep, it's very hard to wake someone up from stage 3. And young children have more of this deep sleep, and that's why they're harder often to arouse than an adult or you or I. Now, that's what we call non-REM sleep, non-rapid eye movement sleep. And those different brain waves make up about 75% of our normal sleep pattern. But about 25% is made up in rapid eye movement sleep. And this is generally when we have our dreams. Our most vivid dreams are in the REM sleep. So when you wake someone up out of REM sleep, they'll often have a story of something going on. And in REM sleep, the brain activities kind of similar to stage 1, but there are these phasic eye movements, as if someone is looking around at something that's going on. And these are distinct for the REM pattern. And then very importantly, all the muscle activity reduces to nothing in the REM sleep. So every night we all become like a quadriplegic in terms of our muscle activity. All our postural muscles become completely silent. And that is so we don't get up and start acting what we're dreaming about. Yeah. So these are the distinct signs of REM sleep. So in a normal sleep pattern, we have this sort of this structure of sleep where we move from the different phases. And so in this diagram, the different phases are given different colors, so that stage 3, that deep sleep I was talking about, is the sort of darker blue here. And the REM sleep is the red. So you can see there's 4 periods of REM sleep. We have most of our stage 3 in the first third of the night. And this is thought to have some sort of evolution has brought it on this way, that we have most of our good sleep in the early part of the night, so that probably if we were unable to get a full night, we'll have at least had our most useful sleep in the very first part of the night. Within that first 180 minutes and within the first 3 hours, we'll have had 2 complete phases of sleep in that time. But, you know, these across the night here, going through all these phases might, you know, take up to, 6.5, 7.5 hours. So one of the questions that people often ask is, because maybe your doctor's wanting you to have a sleep study at some stage, one of the questions that might be asked is, well, should I do a home sleep study or should I do one within the sleep lab? And the bottom line is that certain studies suit certain people, but fundamentally, scientifically, they're very equivalent, doing it at home versus in the lab. At our unit, we do all home studies because generally we find that they're quite doable. Patients prefer to take the kit home and sleep in their own environment, in the privacy of their own home, without being watched by someone else or sleeping in someone else's bed. But we make all these measures in a home sleep study that we would in a lab. We measure brain activity, eye movements, muscle activity. We measure the heart rhythm, the position that the person's sleeping in. And normally a home sleep study will focus on breathing because we're looking at whether there is a breathing problem that's disturbing sleep. And also we might measure the leg movements as well, because some people have regular leg movements, periodic leg movements in their sleep. And measuring oxygen level is important for health and brain health and for long-term cardiovascular health. So yeah, do the type of sleep study that might suit you. Some people don't want to take a kit home and put it on themselves. They'd rather go in and be looked after in a sleep lab and use that type of environment. Now, in understanding poor sleep, it is important to understand what happens normally across the age. And usually poor sleep, in general, starts to bite in sort of middle age and beyond for a lot of people, although people with chronic conditions can certainly start to experience these things much earlier on. Yeah. But if we look at the changes in the sleep phase over age, so here you can see age is on the bottom axis from 5 years to 85. And then these are minutes here on our y-axis, and these are the different phases of sleep. So you can see that slow wave sleep, the stage 3 sleep that I was talking about, the deep sleep, it naturally just gets less as we get older. So we naturally have a lighter sleep as we get older. We're more likely to be waking up to various things, and we have less of that long sort of deep sleep that we experienced in younger age. So one of the things I think to think about is just our expectations of sleep, that when I'm sleeping as a 55-year-old now, I'm not going to be sleeping like I was sleeping when I was 20. I am expecting that perhaps my sleep would be a bit more disturbed and somewhat lighter than it was. And that's just the natural physiology of the brain and the way sleep stages change. You can see this thing here, this WASO category, and that's wake after sleep onset. So that's when you go to bed, but then you wake up again and you're awake for a period of time across the night. And that will naturally increase with age, but there are various factors that might contribute to that, like, for example, pain, for example, or the need to get up to the toilet. You wake up and you need to get up to the toilet, something that tends to happen more as you get older. And then it might be slightly more difficult to get back to sleep after you've been to the toilet. So this is to be expected, that this time of wakefulness throughout the night will increase. But interestingly, the time to get off to sleep doesn't change much as you get older, and the REM sleep doesn't change much either as you're getting older as well. So people ask sleep professionals, well, how much sleep do I actually need? How much is enough? And we try to be very obtuse when we answer this question because the true answers are not known emphatically. But we do know that in animal studies, that if you deprive animals totally of sleep, that they end up dying. So a rat that's deprived of sleep will die within 11 to 22 days of total sleep deprivation, where they not allowed to sleep. If you deprive them of certain stages of sleep, then they will also die as well. So just selective rapid eye movement sleep deprivation will cause the rat to die over time. As the rat becomes more sleep deprived, it will start to demonstrate certain behaviors, disheveled and clumped fur. So the rat doesn't look after itself like it was looking after itself before. It will start to develop skin lesions, and then it will lose weight. Even though it's eating more and more, it will be unable to digest the food and get the nutrients. So these are some of the effects that sleep deprivation of an extreme type will have in an animal. And we believe these same things will happen in a human that's deprived of sleep. So it's not good for the normal physiological functions to deprive yourself of sleep. And there's a number of studies in human beings showing, increased obesity rates, increased rates of various cardiovascular diseases and diabetes in people who are not sleeping long enough. So when we answer this question about how much sleep is enough, we'll quiz the person about their own personal experience of their sleep, but also, very importantly, their daytime function. And one metric of whether you're sleeping enough is just how are you functioning during the day? Are you sleepy during the day? Are you alert enough to do the types of things that you want to do? Or are you not? Are you, when you get in front of the TV and you want to watch the news, are you falling asleep or unable to concentrate rather than staying awake at that time when you'd like to? Alterations in your mood might occur if you're not getting enough sleep. These may not be noticed by the person themselves, but they're the people that they're living with, their spouse or their significant others may notice irritability, etc. Your cognitive function may be reduced, memory, ability to solve problems, this sort of feeling that you've got a foggy head. And then immune function can be affected as well. You're more likely to pick up bugs and things when your immune system is depressed and immune function is modulated by sleep. This is one study that looked at a huge number of observations in females. It was based on 636,000 observations of sleep duration and the length of life. And interestingly, the ladies that lived the longest were those that reported having 6.5 to 7.5 hours of sleep. And this sort of U-shaped curve around that optimal amount of sleep. So one of the things to note about this is that often people will say, oh, you need 8 hours of sleep to be normal. Yeah. Well, we don't necessarily think that, and perhaps a shorter duration of sleep is going to be acceptable. You know, usually we sort of think around 7 to 7.5 hours might be something to aim for. But I think really one of my messages would be is to don't look at others and their sleep. Look at what you're doing and then try and modulate your own sleep. You know, if you're sleeping only 5 hours a night and we can improve that to 6 hours, that is a huge improvement within yourself and will often be associated with many of the improvements to these sorts of factors that I've talked about here. Yeah. So don't look at others and the performance of others. These things are just guidelines where we might sort of roughly aim for, but you need to look at yourself. Yeah. And, you know, in chronic disease, many people need to sleep long periods of time to get adequate rest. So these sorts of recommendations around optimal periods of sleep just don't apply, because to function normally, you will need to sleep for long periods of time, and that's the right amount of sleep for you. So in understanding how to sleep better, it's important to understand the sorts of things that are driving normal sleep and the normal rhythms of sleep. So this is one of the models. This is called a two-process model, where how we understand how sleep works. And these two important factors for sleeping are the circadian rhythm, our natural rhythm for sleep, which is actually determined by a part of the brain, the suprachiasmatic nucleus. It's got like a pacemaker in it, which is a 24-hour pacemaker for various physiological functions, but one is for sleep. So that nucleus acts on the pineal gland to secrete a substance called melatonin, which is a trigger for sleeping. So here you can see this circadian rhythm across the 24 hours. You can see the sleep period here for this person, which is between 11 p.m. and 7 a.m. So they're getting an 8 hours sleep here. And you see the circadian rhythm occurring at the same place each night. And then the other factor is this process S. That's called what we call homeostatic drive, or the person's drive to sleep, the brain's drive to sleep. And basically that is the fact that because you've been awake all day, you are probably more likely to be tired come 11 p.m. and be wanting to fall asleep at that time. Versus 10 a.m. in the morning, you haven't been awake for very long. There hasn't been very much drive built up to sleep. So unless there's something disturbing your sleep, you will find it hard to fall asleep at that time. So these two factors in a normal sleep pattern work in concert to keep the person awake during the day and alert, and then sleeping across the nighttime period. So when we try and improve someone's sleep, we work on these various factors to try and enhance the normal physiology of sleep. And one important factor to understand when you're trying to improve your own sleep is to understand that you will fit into this model. You're not unique. You're part of the human race, and your physiology is the same as everyone else. So these factors do apply to you, and if you apply certain behaviors, things will start to change with time. It may not be easy, but you think you can gain improvement by manipulating these various factors. And I'll show you sort of how to do that. Yeah. Now, the thing is that, as I've said, we don't sleep as well as we get older. And one of those factors is because we have less of this melatonin. This circadian cycle doesn't work as well as we get older. So you've got to often work harder at sleeping well when you get older, unfortunately. And it's like a lot of other factors as you get older. You just need to be more focused on good behaviours as you get older. When you're 18, you can get away with some bad behaviours and sleep okay. But as you get older, the physiology is working against you. So here you can see the melatonin levels at different age ranges. Yes, and young people are blessed with the huge secretion of melatonin at nighttime, versus older people have less of that secretion of this sleep triggering hormone for sleep. So that's one factor just to take into consideration. Yeah. So, you know, give yourself a break, because unfortunately the physiology is not towards us as we get older. Now, the circadian cycle is being determined by the melatonin, but there are other factors that are triggering the cycle and when it occurs. And one of those important factors is light and darkness, when we expose ourselves to light. And a really important feature of getting a good, healthy circadian cycle is to try and get morning light if you can. You know, so waking at roughly the same time every morning, and if you can, expose yourself to direct sunlight. So, you know, open all your curtains, go and sit in a sunny place. If you can, go outside and do the garden or whatever, or go for a walk in those early couple of hours, because that exposure to light will ensure that your circadian cycle happens at roughly the same time every night. If you're doing that sort of thing, you're more likely to feel tired at roughly the same time every evening. And then not exposing yourself to too much light in the evening or across the night. So exposure to TVs and computer screens too close to bed will inhibit the melatonin and reduce the effect of the circadian cycle. So, you know, it is a bit of a no-no for sleep professionals. You know, if someone wakes in the middle of the night to go to the toilet, that they then go and watch TV for an hour or something like that, because you'll be getting all that light into the eyes, and that will be reducing the strength of the circadian cycle. So here we can see a normal circadian cycle here. This is a movement detector, and these are the days here. Each line is a day. You can see them numbered out, and the blue is marking out the period of inactivity for the person. So this is when they're sleeping, and you can see a natural human cycle, the normal circadian rhythm. Over here is an experiment where they put people in a very, very dark environment and let them go to bed whenever they wanted to. So they didn't know when it was day or night. And this is what all human beings will do. If you put them in a very darkened environment, they'll start to go to bed later and later and later every night. And this illustrates that the normal circadian rhythm is not 24 hours, it's slightly longer. And so there's this natural tendency for our rhythms to go out of whack. It's the way the circadian cycle works. So rejigging our rhythm by exposing ourselves to light at the appropriate time and not too much artificial light in the evening is important. Yeah. And there are various filters and things that you can put on your devices to limit light. There are sort of glasses you can buy that will reduce the effects of artificial lights. So this shows you the two process models. I've talked about the circadian rhythm and I've talked about the effect of light. And here you can see the circadian rhythm going along here in a person who's actually skipped a whole night of sleep. So they've stayed awake through a whole night, through the whole day, and then they've gone to sleep at 11 o'clock the next night. But they've built up an almighty sleep pressure by not sleeping for a whole night. And this is one of the things we try and do with people when we're trying to help them sleep better, is we will slightly deprive them of sleep to try and build up sleep pressure and getting them to sleep better across a shorter window of sleep where they can actually get a consolidated sleep. But this just illustrates like another factor in the two process model. Now, there are common sleep problems, and the thing I'm going to mainly talk about is this poor sleep and insomnia type issue. But there are many sleep disorders. Sleep apnea is one I might touch on if we get time. As I've mentioned, periodic leg movements, people's legs jerk regularly at sort of intervals of 15 to 45 seconds across the night. And this is very closely linked to restless leg syndrome, where a person feels an uncomfortable feeling in their legs and they want to move their legs or get up and get walking. These two conditions are very commonly go together, and these can disturb sleep. REM behavior disorder is a disorder where the person doesn't have that loss of muscle activity and they can actually get up and start acting out their dreams at nighttime, sometimes with very devastating consequences for the bed partner. And there's been multiple homicides due to people acting out their dreams at nighttime. And then there's circadian rhythm disorders, so where the rhythm is out of time, both advanced sleep phase, where the person's going to bed too early, or delayed sleep phase, which is something you associate more with sort of teenagers, where they're going to bed late and they're wanting to sleep in. So there's this natural tendency for the circadian rhythm to be delayed. And this is why there's been many proponents that teenagers should start their working day much later than we all do, because they have this tendency to want to sleep longer. It's the way they're wired physiologically. So in talking about insomnia and poor sleep, this is like a formal definition of insomnia, and it's helpful in some ways, but in other ways it's not, because you can see that the duration characteristics of a formal diagnosis of insomnia is that you must have the symptoms for 1 month. Well, personally, if I've had poor sleep for 2 nights, I like to try and do something about it, and so I will change my behaviors if I start to sleep poorly and implement some of these things that I'll talk about in tonight's talk. But the formal diagnosis is a long duration of being unable to sleep effectively. And the definition is it's a subjective complaint of difficulties initiating or maintaining sleep, or non-restorative sleep. You feel like your sleep's not doing anything for you. But importantly, it's subjective. It's your reports about your sleep rather than something as such that we can measure so much in the sleep lab. And it results in daytime impairments such as mental and physical fatigue, a thing called sleep anticipatory anxiety. And what that really means is that people with poor sleep think about sleep more. They get anxious about their sleep, the fact that they're not sleeping well, and that may have consequences for them. This is a very common feature and something that will come up again and again as I'm speaking. And then perceived neurophysiological deficits. So people with insomnia say, I'm performing worse, because I've got this sleep problem. But when you measure them, often their performance is quite adequate and not at deficit. So sometimes it can be the perception you're not functioning well rather than the actuality. And so it's important to just let people know that with poor sleep that, you're still probably functioning quite well, even though you're not sleeping as well as you would like. So this is sort of a model which describes how someone might end up having insomnia and the various factors that might contribute. So we're moving here from the left-hand side where a person doesn't have insomnia. This is their pre-morbid condition. And up here is a dotted line. That's the clinical threshold. That's where a person will say, I'm sleeping poorly, or I think I've got insomnia, when they hit this threshold. So we all have various sort of pre-morbid things around thinking about, our well-being and how well we're sleeping. That's just natural. It's natural for all of us to want to sleep well, and we'll all have a degree of sort of concern about our sleep, and we'll have naturally people who are lighter sleepers than others. That's their pre-morbid condition. But although you might think about your sleep, it's not enough to reach this insomnia threshold. Now, usually there's a precipitating factor before someone says that they're sleeping poorly. And these sorts of things might be something like grief, for example. You lose a loved one or a friend. It's extremely stressful, and you start to worry about that, and then you start to sleep poorly. Or you might, for example, experience pain, or something's happening with your health. You might get a cough. It might be coughing a lot again and again and again, and you start to sleep poorly. So there's some sort of precipitating factor that will push you over this threshold, and you'll start to say that you're sleeping poorly. And there's real factors which are causing this problem. And this is acute insomnia, and we address the acute factors. So at some stage here, it may be appropriate to take sleeping medications and things to help a person with anxiety or pain or whatever at this stage. But then over time, what happens is there starts to be perpetuating factors, where the person starts to worry more and more about their sleep, or they start to spend longer and longer in bed trying to make up for poor sleep. And these factors start to increase over time. And eventually with time, the actual precipitating factors wane away. The pain goes away. You start to be less stressed about a job you've lost, a job or a job change or whatever. But these perpetuating factors may persist, and the person then goes into a chronic insomnia type pattern. And it's these perpetuating factors that we want to work on and help people with, to bring them to below that threshold, so they're now sleeping normally again. So here I've just put out here what these factors might be, just to illustrate to you. So our perpetuating, predisposing factors, here, like light sleep, over concern with your well-being, or an introspective and worrying disposition might be here. Pain, occupational change, acute stress, and then our perpetuating factors are things like, excessive focus on sleep, increased time in bed while you're actually awake, or something like taking a daytime nap. If you take a daytime nap, you're going to alter that process S, that sleep drive. You're going to make that sleep drive less, and you're also going to alter the circadian cycle. So we generally recommend, if you can, not to nap during the day unless you really need a nap. Generally, we recommend, if you are going to nap, just a 20-minute power nap before 3 o'clock would be preferable. I understand that in chronic disease, people will need longer sleeps, and some people just won't be able to function unless they have a much longer nap than 20 minutes. And so you will need to take that into consideration in terms of my general recommendations about sleep. But if a person is sleeping poorly at night, one of the things we look at is the number and duration of the naps that they're having during the day. Yeah. So in chronic conditions, there are many things that might impact sleep, and this is just a very brief list, and I'm sure that the listeners can come up with many more things, but these are the sorts of things that might occur. Pain, as I've talked about, physical limitation to changing your position, coughing, lack of physical activity and weight gain, increased demand for daytime naps. You need to take naps, but they can tend to be really quite long. Waking at night to urinate, and various medications can be either sedating or alerting within chronic conditions. So it's not easy because you've got all these other factors that are impacting in on sleep. So I'm not saying that implementing my behaviours is going to be easy, but it's been shown again and again in research that even under the most dire conditions, if we implement behaviours to improve sleep, it can lead to beneficial change in sleep and quality of life. So this is just one example here in chronic pain patients. So this is a study done in a chronic pain clinic. And what they found was that there was a huge number of the patients reported a sleep complaint. In fact, 88% of the chronic pain patients reported a sleep complaint. Whether that be getting off to sleep, being unable to get back to sleep in the middle of the night, waking up too early, or a mixture of a number of things. Only 18% of the clients had no sleep complaint. Now, one interesting factor is it works the other way as well, that when a person doesn't sleep well, their perception of pain changes. And so this is a study where they deprived people of sleep and then measured their tolerance to pain. So they're very nasty experiments here where they'll put the person's finger in a thing like a vice, and they'll turn the vice, and then they'll sort of see how much pain the person can endure. And they'll do that in a rested state, and they'll do that after they've deprived the person of sleep. And interestingly, the person can't take as much painful stimuli after they've not had sleep. Total sleep deprivation. Now, interestingly, if you deprive them of either the REM phase or the slow wave phase, the stage 3, you have a similar response, that they also are less able to tolerate pain. But when you then give them recovery sleep after this experiment, they're able to endure even more painful stimuli than they did before. So it's interesting that if we try and augment sleep and improve sleep, it may actually work the other way to affect the person's underlying condition, that if they sleep better, their pain tolerance will be greater. And this is one reason why rheumatologists, for example, who deal with people with arthritis, commonly are referring people for sleep studies, looking for disruption to sleep as a way of modulating the person's pain levels. So this is the study that I was showing you from the chronic pain clinic, where they looked at various factors about people's sleep and also their function. And what they found in this study, I think I'll just advance one slide. So they also looked at various pre-sleep arousal states, and I'll show you that in a moment. My little box didn't come up, but what they did show is that the paucity of sleep in insomniacs, so they looked at things like sleep duration and sleep disturbances, and those factors which are down in insomniacs, which when they sleep poorly, are also exactly matched in the chronic pain patients. So all those poor sleep parameters were matched in the chronic pain as just as the same as the insomniacs. What they also found is that the people with chronic pain had all the same sorts of features as someone with insomnia. They had racing thoughts, they had intrusive thoughts, depressive cognitions, they worried more. Yeah. They reported these sort of physical occurrences like a rapid heart rate, muscle tension, and a feeling of shortness of breath. So these are all signs of pre-sleep arousal that we see in people with poor sleep and insomnia. And they're occurring in a group of chronic pain patients who are sleeping poorly. So we can see that the pain can then act physically on the person to sleep poorly, but it can feed into these perpetuating factors for poor sleep. So when you look at groups of people who are sleeping poorly, they have these common features, and it's good to just look at these things and look at yourself and say, are any of these things happening to me? Could these be the reasons why I'm not sleeping so well? So these common features of people that report poor sleep is they have an excessive time in bed, and particularly they have an excessive time in bed while they're awake. Now, I know this is difficult in chronic conditions because you may need to spend time in bed just for physical rest because of fatigue or whatever. So, although I'm trying to suggest spending less time in bed awake, in some cases it's just not possible for some people, and I do realize that. So this is a general principle. Irregular times of retiring and arising. So we should try and have regular times, particularly of arising in the morning. Trying to have the same waking time each day is one of the keys to perhaps getting a better night's sleep. Trying to retire at roughly the same time, but if you're not ready for bed, if you're not relaxed, then you will stay awake until you are ready to go to sleep. Unpredictability of sleep. So people who sleep poorly, they lie there and they just don't know when they're actually going to go to sleep or wake up. People tend to worry about their daytime deficits, as I've already mentioned. Multiple bouts of napping and fragmentation of sleep. So a person who's sleeping well might nap once, twice, 3 times across the day. Their sleep at night might be more like taking naps than a consolidated block of 5 or 6 hours of sleep. Maladaptive conditioning, that's when you start to do things that you think are related to your sleep. So you have the curtains in a certain kind of way, or the bed covers in a certain kind of way, and you think that that is associated with getting a good night's sleep. So you start to get into all these behaviors that are not associated with your sleep at all. Increased caffeine consumption, and this is really important to reduce caffeine consumption, particularly if you're sensitive to caffeine. And so we will get people to restrict caffeine consumption after midday, and certainly even before midday, if the problem still persists, we'll get them to have their caffeine earlier and of less in volume. And then using sleep medications and alcohol to help sleep. Alcohol will help you get off to sleep, but then the sleep in the latter half of the night will be much worse for the ingestion of alcohol. So these are some of the things that I want you to think about then in promoting healthy sleep in your self, and they're all basically harking back to the background that I've already set, and some of the practical advice that I've given already. Yeah. So one important thing is not to worry if you don't sleep. Try not to worry about it. Be somewhat blasé about the fact that you're not sleeping well. And don't worry about it. If you talk to a good sleeper about how they sleep and you say, well, how do you sleep so well? Often they will look at you very blankly because they don't know why they sleep so well. They just naturally do it. And they certainly, one thing they do is not worry about how they will actually sleep. So don't have unrealistic expectations, as I've already mentioned, and the sort of expectations you could have would be modulated by the material I've already presented. Yeah. Sleep should just be automatic. You can't lull yourself off to sleep, really. Yeah. And efforts to initiate sleep can often be counterproductive. So trying to sort of, think yourself to sleep. Dealing with a racing mind is something that's very, very difficult, especially in modern society. People's mind is racing about various concerns and worries that they might have. And there are various ways of handling that, various psychological techniques that work for different people around relaxation techniques. One important thing is just putting the day to rest. So if your mind is racing, what often people could do is just before they go to bed is to sit there with a piece of paper or whatever and just write down things that are concerning you that you need to work on. Some people will even put that beside the bed at night time, and if they wake and have a thought about something, they'll actually write it down and then just put the thing to bed. So bed shouldn't be a place to solve your problems and be thinking about things. Write them down and document them, and the day is just put to rest. Allow time to unwind in the evening. Turn the computer and the TV off at least 1 hour before the time that you're intending to retire, and maybe start to get to bed yourself ready for bed much earlier, in that putting on your pajamas and doing your teeth and stuff earlier in the evening so that you're ready for bed, and it's not just a mad rush to do all these things before bed, and then you go into bed and then you can't get off to sleep. So give up trying to sleep. So one of the things that I do with my clients is get them to do imagery where they imagine themselves in various situations. So a number of my patients, for example, might play golf. So when they can't sleep, they will imagine themselves at the golf course playing a round of golf. And they will imagine themselves swinging the golf club, hearing the birds, smelling the smell of the grass, all the sounds, the feel of the sun on them. And this is the sort of imagery that they do. And they play one hole to another, walking to the golf ball and hitting the next shot. And this can be a way of distracting the mind and helping them putting a racing mind to bed. Now, for some people, it won't be golf. For me, it might be going on holidays, going to the beach, going to a cafe or something like that. But it's got to involve the senses, the sense of taste, the sense of smell, the sense of feel. And so come up with some imagery that lasts for a period of time and work through your story can be very helpful. So have a bedtime ritual in terms of this sort of what you do as you're going to bed to help relaxation. You can use some techniques, as I've mentioned. Do not use bed as a place to solve problems. One important piece of advice is to not have a clock that you can see beside your bed or in the bedroom. If you need an alarm to help you get up in the morning, have your alarm, but turn the clock around so that you can't see the clock during the night. And if you wake up during the night, you won't know what time it actually is, because that's not helpful to getting a good night's sleep. It doesn't matter if it's 5 hours to morning or 30 minutes to morning for a person who's not concerned about their sleep. Right? You know the alarm will go off if you need it in the morning. And often it will be good to have that same wake time each morning. You wake, you get out of bed, you open the curtains, you get light, you get on with the day, you get very active as soon as you can, and then get as much of that sunlight as you can. And you can actually get glasses that will provide light stimulation, and you can actually buy light glasses and use those instead of going out into the sunshine, and they can be quite useful. They're commonly used in, say, the winter months. Do some exercise during the day, but not too close to bed, not generally within 4 hours of your sleep. Don't eat large meals close to bedtime. Limit your alcohol and caffeine. I've said before 12, and alcohol before 3. And keep the bedroom darkened. We don't want lights coming in to the bedroom. That early morning light can be detrimental to sleep. So here is some principles around sleep restriction, and I won't there's a lot here really, but these are, I think I'm going to make the slides available, so you could certainly have a look at this if you're interested. But the principle being illustrated here is that we don't want to be spending too long in bed awake. We try and restrict the time that the person's actually in bed and try and get them sleeping better by restricting that time. And key to that is waking up at the same time each morning and not going to bed too early, having a threshold time for going to bed. And if you're not sleeping well across the night, what you will generally do is shorten the time in bed rather than lengthening it. Once you're sleeping about 90% of the time you're in bed, then you can slowly increase the time that you're spending in bed. Now, you will tend to get tired during the day if you do this kind of thing. You have to stay very physically active, and I encourage people when they're doing this kind of thing to set themselves some tasks around the house, clean some cupboards or whatever that you might need cleaning, or do some spring cleaning or other tasks around the house, because in the evening you're likely to get quite tired, and rather than sitting down, if you're able to do some tasks. And they don't need to be ones that are moving around, but just where your brain can be active. And then the other important factor is what we call stimulus control instructions. And they're the fact that if you're lying awake in bed and the brain is active, often it's good to just get up out of bed. So get up out of bed, go to another room, sit there in a chair. Don't put on too many lights. Have a lamp or something where you could read a magazine or do something that's relaxing. Don't use a computer or TV, and then just read your magazine or book until you're ready to go back to bed. Then go back to bed, and then it'll be more likely that you'll then fall asleep. But if you lie in bed for too long awake, you'll start to associate the bed with being awake and an active brain. I know this is hard for some people with chronic conditions. They're not able to get up out of bed as easily. So, these things are more difficult and you've got to modify them. But the main principle is to just stay relaxed about the fact that you're not sleeping. Don't be concerned about it. One remedy that I find for some people is just try and lie there with your eyes open. Can be quite helpful. Don't try and sleep. Don't try and wait for your eyes to close or hold your eyes closed. Just lie there with your eyes open in the darkened room, and that can be a way of distracting yourself from this thought about wanting to fall asleep. So yes, I've given you some practical tips, but there's a lot more that you could potentially get into. And this slide sort of goes through some of those resources that people can use. There's a self-help guided course that you can work through that works through this kind of thing. I've written a guide to better sleeping, which can be found on our website. For many people, it might be a matter of there might be more deep sort of psychological and mental health issues underlying their poor sleep. So you might want to go to the Beyond Blue site or talk to your GP, the psychologist or a sleep physician about the problems that you're experiencing. But these are some, hopefully, resources that you'll find helpful that will sort of complement the sort of stuff I've been talking about already. So I think that's sort of a natural place where we could take some questions. Yes, it is. Yeah. So.
Wow, thank you for that. Is there a few more slides after this, or are we going to do just questions, or what do you want to do?
Well, I've got a little bit about sleep apnea. If people are interested in that, a few slides.
We might do some questions and see how long they go for.
No, I think.
Oh yeah, because it's only like 7:05, so we've got a bit. But yeah, let's Darcy's probably compiled a bit of a list, and there's some popping up in the chat here, so might pop over to Darcy and yeah.
Yeah, so one of the questions we got earlier in the chat was, is there a difference between sexes? So can your sort of hormone levels be affecting sleep and things like that?
Yes, and certainly, well, things like menopause, can have a big effect on sleep and the physical changes around menopause. Yeah, so yes, the answer is yes, but it will sort of vary on the time of life and what's going on. Yeah, it's not really my area of day-to-day expertise. Yes, yep.
Another one we had, someone sent this through our event, but tips for getting the doctor to take you seriously if you're feeling like you're needing extra medication or some sleeping pills or some extra help.
Oh, gee, that's tricky. I suppose putting it on the agenda, I suppose, would be something. I mean, making a specific appointment about that specific thing that's troubling you, I suppose would alert the health practitioner to how you perceive the importance of that matter. Yeah. And then, having adequate time allowed for that type of appointment. I don't know if I was trying to manipulate a health practitioner, but I'd book a long appointment to discuss my problem with poor sleep. So adequate time has been allowed for it, and you can really express what is going on, and then obviously document carefully what you're doing. So many of our patients will keep like a diary of their sleep, the things that are going on, so that you can sort of express the full nature of what the issue is, and then maybe pressing the professional on the need for a referral to a sleep specialist. So sleep physicians really are considered to be the pinnacle of consultation in regards to sleep. So if you're not getting adequate advice at a GP level, ask for a referral to a sleep physician to have your problem looked into. Frequently, they will want to do a sleep study, a further investigation, and frequently sleep physicians work with psychologists who do the behavioural side of things as well. Yeah, but there are a lot of good self-help resources available now on the internet and things as well. Yeah. Yep.
We have a self-advocacy talk in this seminar series coming up later in the year, so that might be an interesting one for the person who wants to be getting more out of their GP visits and medical visits. Just put a
Yeah,
spruik in there for our later series.
Yeah, I mean, I think it is important because in my practice, I do see people who come for a sleep study and they have been complaining about these sleep symptoms for 10, 15 years, for example. They've explained it to their GP years ago and been fobbed off, sort of thing. Yeah, and then they've just forgotten about it and just put up with it. Yeah. And then eventually their GP might have changed, for example. So they present this same symptom, get sent for a sleep study, and within 3 months, their whole life has changed. Yeah, in terms of, so it does, I would encourage people to be forward in terms of, yeah, being an advocate for your, being an advocate for your health outcomes. Yeah, yeah. And not just, slavishly just following what the, all health professionals are human beings, I suppose, and they have a perception. So, yeah, you've got to be an advocate for your own health outcomes. Yep.
Yeah, we have a few more questions from the chat, but if anyone wants to just jump in and ask that question themselves, they're very welcome to. The last one we have is that kind of recommended 7-ish hours sleep? Does that need to be in a solid block, or can that be in kind of smaller chunks if that's what's working for the person?
Yes, it can be in blocks. Yes, and that's one important thing, is what is working for the person. Yeah, so I will have people say who are retired, for example, and they have a sleep like a teenager. They go to bed at 1 or 2 in the morning, and then they sleep through till to midday. Sometimes they'll wake in the morning, they might have breakfast and their pills and things, and then they might go back to bed and sleep for a period of time, but they wake generally refreshed at 11 or 12, and then they have their afternoon activities and things. Yeah. So I'm not prescriptive as far as that sort of thing goes. It is really what is working for a person and their quality of life and lifestyle. I mean, there are whole parts of the world that have like this siestas, they do have a long sleep in the afternoon. Yeah. But that's not traditionally our sort of Western approach, and in Australia, we tend to sleep in a consolidated block across the night, and that sort of works for us and for the sorts of lives we live, because often we'll have appointments and things to do in the morning time, and things to do. So generally speaking, if sleep is consolidated, it will be more rewarding in terms of you being more alert and less tired. Your ability to function, your reflexes, whatever, will be generally better if the sleep is consolidated. So that is one thing we are aiming at as part of our treatments, but then eventually we just accept what we can achieve in a given person. Yeah, but it's just when there's detrimental behaviors breaking up sleep. So a person's getting up at 3 in the morning and going and working on their computer, on their tax or something like that. It's not good for the circadian rhythm. It's not good cognitively, because you've got a very demanding activity and that sort of thing. So that's not the sort of thing we would recommend. Yeah.
Yeah, just on that note, Grant, we do have a question in the chat about what is the best practice if you're kind of routinely waking up at that 3 a.m., 4 a.m. mark?
Yeah, well, if you are, then you want to try, if you're waking up that and you can get out of bed, the best thing would be to set up somewhere where you could sit in the house in another place with a lamp or something, as I said, yeah, and actually get out of bed, go to that other place and sit there and read a book or do some, you know, activity, whatever, that you're doing that's non-stimulating, read magazines, something relaxing or whatever, until you're ready then to go back to bed when you're feeling relaxed and sleepy, and then you'll go back to bed. But then you will have a set wake up time, okay, in the morning. You won't sleep in beyond that set wake up time. And you'll usually have set that wake up time as the time you can comfortably get up in the morning. And then, so when your alarm goes off, you'll get up and get on with the day. And then the next night, you won't go to bed too early. You'll have set a threshold when to go to bed. So say I set my threshold at 11 p.m. and I set my wake up time at 6 a.m. You know, I'll stick to those hours, that's sort of 7 hours. So because I've been awake during the previous night and I've woken up at 6 a.m., I'll probably feel quite tired at 10 o'clock, but I will stay awake then. That's when you'll do these activities. You might be standing up, you know, might do a lot of ironing or whatever, you know, something where I've got to be standing rather than sitting on the couch watching the TV, where I might just nod off and go to sleep. Yeah. And then once it reaches 11 p.m, then it's my threshold and I can go to bed. Yeah. And then if I wake up at 3 o'clock the next day, I'll do the same thing again. And if it keeps repeating, I will then need to shorten the time that I'm in bed, because I'm not able to consolidate my sleep. So I'll start to get up at 5:45, or I'll set my threshold at night to 11:15. Yeah. So I'll shorten the time that I've got available for sleep until I can get myself sleeping through that middle section, yeah, of the night. And these are the behavioral ways that so they're the two things: stimulus control and restricting the time in bed. Yeah, not napping during the day, because that will just make it more likely that I will wake up at 3. Yeah. So, but there are certain, you know, things like melatonin supplements and things can help people when they're above 50 years of age with these types of problems as well. So you could talk to your pharmacist or your doctor about those things. They can be perhaps an easier way than these rather hardcore behavioral methods that I'm talking about. Yeah. So, yeah, although I'm sorry if it's somewhat complicated, because it is kind of, but it is effective. Yeah. Yeah. Are there any other questions or?
I think some of what you said there speaks to some earlier questions we had about, is it okay to have like a lamp on, do reading, and have warm milk if you're trying to get back to sleep? But from what I'm hearing, you're saying you can do those things, but just try not to do it in the actual bed. Like you need to go somewhere else to do it to help you go back to sleep. Is that kind of answer that question as well?
Yeah, it can be hard for people who've got reduced mobility or whatever, yeah, to do these types of things. Like it's impractical to get up out of bed and sit somewhere else and things. Yeah.
But so could you do the reading and the warm milk sort of in bed, even if you weren't exactly trying to get back to sleep at that time? Would that still be kind of effective low stimulus?
Yeah, in general, I would say yes. People who are more hardcore would probably say no. But I've seen people,
there's more hardcore people. I can't believe it.
Yeah, some of the psychologists are very strict with all the things you can do. Yeah.
It sounds a little bit like the baby sleep training. Like it's almost like going right back to the beginning when people are trying to train kids how to sleep for longer. Yes, that's what struck me as quite familiar.
Absolutely. Yeah. The problem is that human beings habituate themselves to situations. So if you're sitting in a bed reading at nighttime, your body will tend to expect that rather than sleeping. So we just want the bed to be associated.
Yeah, so the bed becomes the association for reading rather than sleeping. Okay, I see what you mean.
Like if I'm a person who's perhaps retired and I don't need to get to work in the morning and I'm wide awake and I think, well, I can have a read of that book that I'm really enjoying. Maybe, it's not, I've got many patients who do these types of
why
things
not, sort of
on
thing.
a chronic basis. Yes. And it does work for them. Yeah. But they can't really come into my office and complain about the paucity of their sleep if they're doing something that we know is not constructive for getting a better sleep. So it's just a matter of, it's like anything in health, I'm carrying more weight than I need to carry, probably. Yes. So, I'm sure a dietitian who was sitting over me this evening would be giving me a bit of a lecture about what I'm eating. Yeah, it's the same thing with the sleep. There's healthy sleep behaviors which enhance good sleep, and we just need to work out what works for us. But if we're not happy with the way we're sleeping, we need to sort of implement some of these things that I'm talking about.
Interestingly, someone's saying, I find that if the person finds that if they have something on their mind, they need to get up and do that thing in order to go back to sleep. It's like the opposite of doing the good sleep behavior. Is that something you come across a bit? Do people have that problem or?
Not so much, but that it depends what the thing is, I suppose. And what it involves. But yes, yes, obviously, yes. If you think you've left the garage door,
if it's a safety concern, probably okay.
If you've left the iron on or something like that, or it depends what it is. But this is where I say, trying to put things to bed in terms of writing things down that are worrying you and thoughts.
I think it's
just saying, I really am struggling with my child and my relationship with my child. Just try to document it and say, well, it's not really going to help me to try and solve it here in bed tonight, but I've written that down and we really need to think about that tomorrow and do something about it. And physically just sort of closing the book on it and saying, we'll deal with that. I realize it's a real concern, but it's not worth worrying about while I'm in bed.
I like the idea of sort of consciously telling yourself those things to help you sort of move past that, those racing thoughts and that sort of sleep anxiety thoughts. Did you have anything else, Darcy, from the chat?
We've got kind of 2 or 3 more questions. So we'll see if we can squeeze these in the last 10 minutes. The first one is about waking, sort of finding it easy to go to sleep, I'm assuming, but then waking up about an hour and a half after. Can you sort of tell us anything about that pattern?
I mean, not really. I mean, that's sort of many of the same things as I've said. One thing I should sort of mention is not to discount the potential that there's some sort of physical issue going on. And that does relate to sleep breathing abnormalities, which are incredibly common in human beings. And that's because our upper airway, the back of our throat, is very prone to blocking off when we're asleep. And that can be that can be because of overweight and obesity, but it can be due to the physical structure of our jaw and our palate and things like that. So often it will be associated with snoring, but it doesn't have to be. But the throat closes over and partially or completely, and that leads to sleep disturbance. So, and it can lead to a person waking up at night time, but sometimes they wake up and they're in pain or whatever, but they're not aware that in fact the stimulus to waking up was a physical thing related to their breathing. So don't underestimate that potential, and that's the sort of thing that can be picked up on a sleep study. And we're commonly seeing people with chronic insomnia who we do sleep tests on, and we find that there's actually a physical cause for their symptoms. And the other thing can be this twitching of the legs at night time as well. And the twitching of the legs will mainly occur in the first third of the night. So the legs twitch, and that can be a reason why the person wakes up. So yeah, we're looking for stimuli, physical stimuli that might be causing poor sleep. You know, your leg twitches, you wake up, and then your brain starts racing about all the worries and that sort of thing that you have, or that you have a breathing problem that wakes you up. Generally, people with sleep disorder breathing are totally unaware that there is a breathing problem going on, even though they are choking themselves in their sleep. So yeah, always have that suspicion that something physical could be going on. We often screen for a physical problem as part of our assessment. So I think that would be a really important message, because when I interview people coming for a sleep study, only a very small percentage of them would think they have a physical problem with their sleep, but a large number end up having such a problem which needs a physical remedy, basically. Yeah.
Yeah, thank you. And the last couple of questions we've got, is it all right to take sleeping pills if the GP prescribes it? And is it okay to listen to a podcast or talkback radio?
Well, yeah, certainly if your GP has referred something, yes, yeah, it can be quite appropriate to take medications, particularly in the acute sort of phase of a problem. But don't underestimate these behavioural approaches. I mean, all the studies tend to suggest that taking medications plus doing these behaviours in the early stages, and then the drugs can be weaned away over time, and the behaviours are just implemented. Yeah, the taking of sleep medications on a chronic basis is often associated, you know, with well, ineffectiveness over time and certain side effects. Yeah. So we tend to try and do these behavioural things. Yeah. What was the second part of that?
Sorry, is it okay to listen to podcasts and radio?
Yeah, well, the answer to that question is it tends to be not, because again, you tend to associate your ability to sleep and the sleep, you know, with that activity. Yeah. So the hardcore answer to that would be no. You know, in bed you should be sleeping, but people will report that these things work well for them because it distracts them and it relaxes them. Yeah. So another factor that's important in sleep, I mentioned the circadian rhythm and the drive to sleep, but another important factor is the cognitive factors, the activity of the brain in a given moment. So if you can make yourself more relaxed with a podcast, you will feel that you do fall asleep better when you actually do that activity, but it will make you probably reliant on that ongoing. You will need to have the podcast there all the time because that is part of the, you know, that is part of your sleep. And for people, that is okay for them. And yeah, but if ever that wasn't available, then they would probably experience quite a difficulty with their sleep. So yeah, so many psychologists would consider, you know, my answer to be sacrilege if I'm recommending anything other than pure healthy sleep. Yeah, yeah.
We won't tell on you. We promise.
Yeah.
I think we are pretty much at the end there.
Yep.
So if it's okay with you, we will share those slides to the people who have come to the talk tonight, because there is a little bit more on sleep apnea that people might like to read about.
Yes, I sort of just got that in there. I just sort of mentioned that. So
yeah, that's really great. So we want to thank you so much for giving us your time and explaining all these wonderful concepts. And I feel like I'm going to run off and get like the healthiest night's sleep that I've ever had in my life tonight as a result of this talk. So I'm really excited about that. We at the Healthcare Consumers Association have a few websites. The Canberra Health Literacy website has lots of information and things on how to get the most out of your medical appointments and lots of other resources like that. So if people want to pop over onto our websites and check out some of our fact sheets over there, that might be helpful. We would love for everybody to fill out a survey, like a very quick online survey about our talk tonight. Just to help us understand if you enjoyed it, if it was great, if there's anything we can change. And the link to that is in the chat right now, or we'll email that out as well. So I think that's, oh yes, this is the first one in a series of these managing your health, what's the word I'm thinking of, seminars. So the next one coming up is about exercise and chronic conditions. So if anyone's interested in that, there's a link to an Eventbrite where you can get a ticket for that one as well. And yeah, we have about 6 of these running throughout the year. So keep an eye on our website and we'll let everybody know when they're on. And a big, massive thank you to Dr. Grant. And yeah, I hope everybody got a lot out of that. And we're really grateful that you came along.
Thanks very much.
Thank you. Great, Dr. Grant.